Hello and welcome to Health Matters on Channels Television. Thanks for joining us. I am Mary Alale Yusuf. Almost no area of the body is unreachable when it comes to uncontrollable growth of cells. Not even the bones are unreachable. Bone tumors grow when cells in the bone divide without control. Most bone tumors are benign, which means they are not a cancer and do not spread to other parts of the body. In the past, tumors were treated by amputating or cutting off the affected limb. But with the introduction of microsurgery, the limb can be reconstructed after a tumor has been removed. My guests are a plastic surgeon from the Lagos State University Teaching Hospital with a bias in reconstructive surgery. He is Dr. Abdul Wahab Ajani. He also is a consultant orthopedic and trauma surgeon who doubles as an orthopedic oncologist from the National Orthopedic Hospital in Igbobi. Dr. Bright Igbinoba, you're welcome to the show, both of you.
Thank you.
Thanks so much for coming. Now, let me start by asking, when you say somebody has a breast cancer or, lung cancer, those are soft, cushy parts of the body. But bone, I had no idea that bones had growths. So, what causes a bone growth? You go ahead, Dr. Igbinoba.
Most times we tend to assume that because a bone is hard,
Yes.
that it is an inanimate object. That means it's not a living thing. However, the bone is as living and as alive as every other part of the body. It consists of cells, just like every other part of the body. And as such, it is subject to whatever happens to other parts of the body. So the bone can have cancerous transformation, just like every other part of the body. So if we ask what causes bone cancer, the exact cause of bone cancer is not known. Rather, we discuss in terms of risk factors. That what are the risk factors that predispose to having these conditions?
Okay.
And these risk factors can be discussed along the lines of modifiable risk factors and non-modifiable risk factors.
So there's some modifiable ones,
Yes.
okay?
So the ones that can be controlled, and then the non-modifiable, the ones you cannot control. Let me start with the non-modifiable. For example, the race to which you are born, we can't control it. As a black man, there are some cancers that are more common in black men, like malignant melanoma.
Okay.
So you cannot control that. Then your sex, whether you are male or female, you cannot control that. Some cancers are more common in females.
Definitely breast cancer.
Exactly. Prostate cancers in males.
Yes.
Then your age, you cannot control your age. There are some cancers that are common, like bone cancers, have bimodal age distribution, in that some of them occur in the young, usually in the second decade of life, between 10 and 20 years of age. That's the
So
most common
tender
period.
age.
Period you grow very fast.
Yes.
Then there are others that occur after age 50. So that's the bimodal age distribution. So those ones you cannot control. You just reach your age and you have no control over it.
So what can we control?
Then there are some you can control, like your exposure to sunlight.
Aha.
The lighter skinned people, the Caucasians, they come to a tropical environment
They
like
sunbathe.
ours, and they want to sunbathe. But the sunbathing is exposure to the ultraviolet ray of the sun.
So
it
is
can
it wrong to
predispose-
sunbathe?
Well, it is okay to sunbathe, but whatever we do in life carry risk. So sunbathing can predispose to some cancers.
Okay.
So then alcoholism, chronic alcoholism also predisposes to cancers. Then smoking predisposes to cancer.
Even in the bone?
Exactly. Then irradiation. People that work in X-ray departments.
Okay.
When I mention irradiation, if not doing the routine X-rays, people may become afraid when a doctor asks them to do an X-ray.
an X-ray.
But you have to be subjected to the normal exposure that we have. You have to be subjected to about 1,000 of that in a very short
Could
while.
that be during treatment for cancer?
Yes.
For example?
Yes. The radiation is used to treat cancer, but we also know that radiation too predisposes to cancer. So one has to
So
create
those are
a
the risk
balance.
factors.
Yeah, those are
Now,
the factors.
I need to ask you, these bone tumors, are they on the bone or within the bone? And are they hard or are they soft?
It-
Any of you, I'm sure, can take that question. Dr.
yes.
Ajani just wants to go straight to the reconstruction.
Well, let me still take that.
Go on.
The bone cancers can be intraosseous or extraosseous. When I say
Meaning
osseous means bone, can be
bone.
within the bone
Within,
and
okay.
outside the bone.
Or outside, all right.
The musculoskeletal system is made up of bone and the soft tissue.
Okay.
The muscles, the tendons, the ligaments, the vessels, the nerves that are around the bone. So the cancers can come from the soft tissue or come from the bone itself. Then if it's coming from the bone, it can be within the bone or
Okay.
outside the bone.
Okay, that explains why they were being amputated before.
Yes.
Because they would have destroyed that section of
Exactly.
bone. Okay, so you just want to cut it off and just get rid of it.
Yes.
I see. Okay, you didn't answer whether they are hard or soft.
It can be hard, it can be soft, and can be hard and soft at the same time,
Okay.
depending on what is elaborating. When the cancer cells can come from any type of cells inside the bone. There are some cells that deposit more bone on itself. So as the cancer is forming, it's depositing a lot of bone around itself. So in that case, it can be hard. At times, it can elaborate cartilage, what we call
Okay.
the brisket bone.
Okay.
So those ones too, it can be soft stroke hard. Then at times, it can deposit fibrous tissue. Sometimes the thing about cancer cells is that it grows out of control.
Yes.
The control mechanism in the body, and then sometimes it becomes pluripotential. That means it can go in any cell line.
Okay.
So at times it starts forming muscle, at times it starts forming blood vessel. So you can go in any cell line.
Okay, so
it can
we've
be
been
soft.
using two terms, simultaneously. We talk about tumors and we've talked about cancers. Are we talking about the same thing? Because my understanding is that some tumors are actually benign. They are there, but they're not causing any problem. But when it becomes bad, is that when you call it a cancer?
Okay. The thing is that most cancers are tumors,
Okay.
but it's not all tumors that are cancers.
All right, you've totally lost me there. But
Let me explain. Let me explain.
we'll leave it at that.
Okay.
I need to go on and ask some other things. Does this condition have symptoms? Even if it is benign, wouldn't it cause pain in whoever has it? Like that foot we saw, on the screen, that looks pretty painful. Even if it is benign, even if it is not a cancerous growth.
The two commonest symptoms of cancers are pain and growth. There are pain and swelling.
We're going to see it.
The swelling,
Okay.
yes. So now, the benign ones, most times they start as swelling. They start as swelling. And for it to, initially they will be painless. But for them to become painful, they have to be very large in size to an extent that they are stretching the capsule that surrounds them, or they are impinging, pressing on the nerves or other structures.
That would cause pain.
So that's how it causes pain. However, for the malignant ones, the cancer ones, those ones can usually start with pain. Or at times, pain and swelling at the same time. I mentioned that benign starts with swelling. The swelling is there for a long time. It grows slowly. Then after it becomes very large, that's when it becomes painful. For the malignant ones, the cancerous ones, the cancerous ones, they would start with pain at the beginning, and the pain are usually worse at night. Even before you notice the swelling, there will be a lot of pain.
So there's a way of differentiating what is going on in the body.
It's not clear-cut, but one can hazard a guess.
Okay.
If a patient comes to me that I have swelling, I'm going to ask, is there pain with it?
Okay.
If they say they have pain with it, I'm going to ask them, did the pain come before the swelling, or the swelling before the pain? Or did they come at the same time? So if the pain comes before the swelling or comes at the same time with the swelling, I'm going to start thinking this looks cancerous.
Okay.
But if the swelling has been there for a long time before the pain started, I will start thinking this one may be benign. Then the next thing I'm going to ask, is the pain present at night and at rest? So if it's present at night, more often than not, it's going to be cancerous.
Cancerous. So, Dr. Ajani, when you get a patient whose cancer has been cut out, what's your first reaction to reconstruction? Do you have to do certain types of tests to find out if this patient is a candidate for surgery?
Thank you very much. We need to see the condition of the patient, if the patient will be fit for surgery, because it usually takes a long time. So once there is no pre-morbid condition that will prevent the patient from undergoing major surgery, we can then go ahead to investigate the patient on whether the tumor has been completely removed and whether there is no infection in the bed. Once those conditions are met, we then go ahead to plan the reconstruction.
How do you determine that there's no infection there at that moment,
We have some
that the
investigations with it.
cancer, as
Yes.
it were, has not moved on to somewhere close by?
Yes, this is part of the preoperative workup that must have been done by the orthopedic surgeon. They will check the whole body and see if there is any metastasis to the other parts of the body. Then the bone that is removed too will be sent to the histopathologists to find out if there is no tumor cell left behind before we can go ahead with the reconstruction.
About how much of bone is removed? Because I imagine that if a substantial amount of bone is removed, you will have a space.
Yes.
So that's what happens. You have like inches of missing bone because it has been cut out. So what do you put there?
Well, in my first interview with you, I told you the first principle of reconstruction is to replace like with like.
Okay.
So in my own part, because there are other means of treating this type of patient, but the reconstructive microsurgery, what we do is we take bone from any part of the body and replace whatever length that might have been removed from the leg or any part of the body.
You take bone from any part of the body and replace the length.
That has been
do you grow the bone?
No.
So how does it, I mean, if you take some bone from somebody's leg, for example, to put in a space that has been cut in their hand, what happens to the place where you took it from?
Yes, there's what we call donor site mobility. We know the part of the bone we can harvest without causing any problem to the patient. Like if we want to harvest the fibula now, I will spare the proximal 6 centimeter and also the distal 6 centimeter, which are the part that are usually, functional in that part of the bone. So the other part can be harvested for reconstruction without causing any problem to the patient.
So the bone that you have, when you say you take whatever it is you take, you make that part of the bone smaller where you took it from. Isn't that right?
No.
Okay, so explain this to me.
It's the whole circumference of the bone I'm going to harvest and use it for reconstruction wherever the defect is. So the truth is that there will be no problem with the leg because I'm not harvesting the part that is useful.
Okay.
So I'm just taking that part that is dispensable.
Okay.
From the leg. So
we need to take a break now. When we come back, a little more on this. Please stick with us and come back after the break. Welcome back. We're talking about tumors and how bones can be saved from being made useless, from being amputated. Now you can call 0805 468 3514. That's 0805 468 3514. And you can tweet at CTV_Mary A while we learn more about this very intriguing subject. Very intriguing subject. So you take a part of the bone without affecting the limb and without affecting the function.
No.
Okay. So after you've taken that, what do you do? Will that bit of bone that you took be sufficient to replace what has been cut out?
Of course, because before we harvest the grafts, we're going to measure the length of the defects and transfer it to the bone we want to harvest.
Okay.
We actually even take more than what we need because we're going to need some centimeter to go into the marrow of the bone we are trying to reconstruct.
Okay.
So
in the visuals that we've been seeing, I see that there's something like a foreign body.
Yes.
In the limb of the person. Can you explain that?
Yeah, that's the work of my colleague. After putting the bone in place, he will use we call it implant, the plate and screw to hold it in place so that it does not fall off.
What's that thing made of? Is it metal?
Yes, it's a metal.
Okay, so right after you have cut a section of bone, you put in that metal and you screw it in or what?
Yes.
I didn't know the body was so versatile that you could actually screw on metal into
It's just like having normal fracture. That's what they do for trauma patients.
Okay.
So once the bone has been fixed and the anastomosis, because this is where microsurgery comes in, we are harvesting the bone with the blood vessel, then we transfer it to the recipient site, where we reconnect the blood vessel to the recipient vessel so that it continues to harvest. So the bone, the healing will be just like a normal fracture.
Let's quickly take this call from Jonah in Abuja. Hello, Jonah.
Hello, ma. I just want to confirm something. My brother has been operated from this tumor of the brain.
Okay.
And some plastic has been fixed inside his brain to the body.
Okay.
Hello?
So what do you want to...
how long can this sustain him?
Okay. Thank you very much. That's the brain he's talking about. Is this in your purview?
Yes. Yeah.
So is it similar to other parts of the body when you do this procedure?
Yes,
so he's asking how long is it going to last?
It depends on the make of the materials used.
Okay.
Like this implant we're just telling you, maybe in the next 1.5 years, if the patient wants it out, we can remove it. Okay. So it depends on what the materials that is being used to, operate the patient, because we don't...
What if the patient is not yet ready for, ready for the salvage, ready to have it reconstructed? Can he have that thing replaced?
Yes.
And then take off again?
Yes.
But that would be expensive. You had to open him up again and then screw those things in again. Better to do the surgery. Okay, so you get the patient with this extra metal in his body. Then you have to take it out and then use a graft. Let's quickly take a phone call before we continue that. Hello, Daniel.
Hello. Please, I had an accident for some time. After my leg got healed, I discovered that the right side of my leg became caged a lot. So what do I do, doctor? I've been trying to do exercise to straighten that portion of my knee. So it's been a problem to me. I've been very straight before. So I've been doing exercise and taking drugs. So, but sometimes it will be trying to bend inside. I don't know how to straighten it. Thank you.
Okay, it's like it's bent. Dr.
That is a post-traumatic deformity of the limb.
Is this a usual occurrence?
It may or it may not. It's not usual, but it only happens maybe depending on where the patient was managed. Okay. A lot of our patients go to non-orthodox, use non-orthodox method of managing fractures, and at times it may not be properly aligned.
So does it have to go back for evaluation?
There are degrees of acceptability of the alignment when a fracture heals. Okay. If it is outside the acceptable range, then it will cause more problem and it needs to be corrected. Okay. So what the patient should do is to see an orthopedic surgeon for proper review, for us to determine whether it can be allowed to heal that way or if it needs to be corrected.
Okay. Let's assume that the bone that has been reconstructed is A leg bone, a shin bone. That's the where we have the tibia and the fibula, right? Can that person return to full function? Because he's going to walk on that leg after reconstruction.
Sure.
Can he be normal?
Yes. Most of the patients we've operated in the past 2 years are walking about normally now.
When was this technology discovered?
It's been on for, but relatively it's new in Nigeria.
New in Nigeria.
But it's been on for years.
How many surgeons do we have who engage in this practice?
Well, I only know, I think in Lagos, I can't talk of the whole country, but in Lagos, myself and Dr. Mufiko in Lut.
Just 2 people?
Yes.
Just 2 people? Wow.
Well, it's not only in Nigeria. Generally, it's a very rare field.
Well, but you know, here, okay, it's rare even in other countries.
Other countries, yeah, that's what I mean.
We're getting a phone call. Hello. Oh, we lost Archibong. Please try again, Archibong. So, do you have any fears of post-surgical edema or infections?
Well, pre-operatively and intra-op and also post-op, we will have taken precautions to prevent all those complications, like giving antibiotics, elevating the leg, and physiotherapy. So we do everything possible to make sure they don't have infection.
That's another thing. Your patient has to do a lot of physio after he's been operated on, right?
Of course. That's why it's a teamwork. We have a team in Igbobi that does all this.
And how many disciplines come into this team? The physiotherapist is there.
The physiotherapist and the histopathologist, the orthopedic surgeon, the plastic surgeon, then we're oncologists too. We send them for also radio chemotherapy after surgery. So,
they do have to do radio and chemotherapy.
Yeah, we have a team. You will talk more about the team.
I'm curious, doctor. Radio and chemotherapy. Why do we only use chemotherapy for cancer? Isn't it just drugs? But before you answer, let's get this call. Hello. Daniel?
Yeah, good morning. Good afternoon, sorry.
Good afternoon.
Yeah. I have a question.
Go ahead.
The question is that I used to work out. I think I did some overweight, so my head
Daniel, you have to put off your TV totally so that we can hear you. No, you'll have to put off your TV for us to hear you. Totally off. I think, Daniel. So anyway, I was asking, why is it called chemotherapy? Why not just medication like other regular diseases? I think that frightens people.
The chemotherapeutic agents are drugs that are used to treat cancers.
Okay.
They are different from other drugs in that what we must know is that cancer cells are part of the body. They are living cells that originate from the patient's own cells.
Okay.
So what the body tries to do is to kill, what the drugs try to do is to kill those cancerous cells.
Without harming the body,
without,
really,
as much as possible, trying not to harm the body. Mm-hmm. The thing is that even with normal drugs that we take, they all have side effects.
All right.
All drugs have side effects, but the side effects are more
when it comes to cancer
drugs.
So we use the term chemotherapy.
Yes.
Thank you so much for coming. We have to close. That was enlightening, at least to find out that the nature of bone tumors, bone cancers. Thank you so much, Drs. Ajani and Dr. Ibinogba, for coming to the show. Thank you for being with us through this time. You have a wonderful day. I am Mary Alale Yusuf.